I call upon my next co-instructor, Dr. SACHIN MAHULI. He's a director of Netradarshan Hospitals, Belgaum. He will be speaking to us on myopic CNVM and how to approach it. Over to you, Sachin.
Thanks, Sunil. Okay, let's discuss in brief about myopic CNVMs. I've kept it very simple so that a lot of us could add more points and discuss. Myopic CNVMs are common sight-threatening problems in myopia, and these CNVMs are little different from the CNVMs which we see in AMD and other pathologies. It can happen with any degree of myopia, not only pathological myopia. Now reports are there with even a simple myopia. Pathogenesis of these membranes have been discussed in three theories. One is the mechanical, which is most accepted theory: excessive elongation of the anteroposterior axis, leading to imbalance in pro-angiogenic and anti-angiogenic factor. Example like lacquer cracks, or if the axial length is pretty high, it creates a potential space between the layers of the retina, and which can initiate the membrane growth. Heredodegenerative theory, which the certain eyes are genetically predisposed to develop these membranes due to polymorphism of pigment epithelium derived factors. Hemodynamic theory is very, it's not accepted quite this thing, because this theory doesn't hold good in many of the cases. Now, coming to the diagnosis of myopic CNVM, usually these patients present with recent drop in vision, which could be in the form of scotoma, metamorphosia, or generalized blurring. Now, very typically, we can pick these membranes with a slit lamp bimicroscopy, either by a 90 diopter or a 70 diopter lens. They usually appear as a flat gray lesions. If there is a pigmentation, they indicate that it could be a chronicity of the disease, recurrence of the disease, or it could be partially scarring. So pigmented myopia, pigmented CNVs are very classical in myopic CNVMs, which pigmentation rarely occurs in AMD. So FA, fundus fluorescence angiography, gives us an idea about the type of the membrane, area, and the activity. OCT is very, it's like a first line of diagnostic tool. It's commonly done. It gives us the idea of foveal anatomy, presence of subretinal fluid. It helps in follow-up of the treatments. And it also gives us associated pathologies of the macula, like presence of VMT or ERM along with the membrane. Or there could be atrophic macular hole also along with the membrane. So these are commonly used diagnostic tools. ICGA is of course used in cases of large subretinal hemorrhages when the extent of membrane is obscured by the presence of heme. So differential diagnosis of myopic CNVM would be a dome shape, like earlier Dr. Sunil has already covered all the DDs of myopic CNVMs. There could be just an SRF. All these things can be picked up by this multimodal imaging. What happens to the CNVs in myopia? The natural history of myopic CNVM is like either they go into a scar formation or they go into a complete atrophy of the macula. These are a few pictures of the natural history of the myopic CNVM. Coming to the treatment options, we have three modalities of treatment. One is laser, which is used for extrafoveal CNVs. It induces a lot of scarring, and recurrence is also known in myopic cases. Very rarely used nowadays, but still can be effective in a peripheral or a perifoveal or a CNVM which is away from the fovea. PDT is effective in scarring down the membrane, but best corrective visual acuity with a lot of studies have shown that it doesn't improve the vision with the PDT, but it scars down the membrane well. Anti-VEGF therapies are commonly used and is most accepted form of treatment nowadays. All these molecules, right from ranibizumab to bevacizumab, all have been tried, including bevacizumab, biosimilars, and AFLIBERCEPT. We'll just take each one of them very short. This thing, ranibizumab is like one of the first licensed drug for myopic CNVM. It significantly improves visual acuity, and it's supported by various landmark studies like REPAIR and RADIANCE, who have already shown us that it usually works better with even PRN basis of treatment. Early detection of the membrane is very key in starting this anti-VEGF therapy. Bevacizumab is not an approved drug, but it's used off-label extensively over past 15 years. It has a lot of prospective and retrospective studies to support the use of this drug. But there is an increased concern of systemic side effect, cardiac effects like thrombovascular embolism. These have to be kept in mind, and this also is usually used in PRN basis. AFLIBERCEPT again is a licensed drug for such myopic CNVMs. One earlier study was like Mayer study, which was the first multicentric RCT to prove the efficacy of this in myopic CNVM. It shows sustained effect for a very long time, in terms of improved best corrected visual acuity, and it's a longer duration acting drug, as we all know. Safety profile of this drug is quite acceptable. This is a new drug. As of now, it's off-label for myopic CNVMs, but it is approved for already AMDs and PCVs. It has a sustained action almost comparable to AFLIBERCEPT. Very good visual improvement, and quick response to the CNVs has been seen in many case reports which have been published. Though it needs a long-term studies and more safety profile needs to be analyzed about this drug. I'd like to share a few cases which I treated and which I thought would interest all of you. This is a 55-year-old lady who had already taken multiple injections, which is very unlikely in myopic CNVMs because they do well with very few injections. This was the case wherein it was not responding to ranibizumab and bevacizumab. Her visual acuity was 6/12 and 6/16, the respective eyes. So this was the picture when I had seen her following the injections. So this was the earlier pictures. So this was the response to AFLIBERCEPT. With one dose of AFLIBERCEPT, it did well, and it is still maintaining quite well with this. So sometimes we need to switch injections to understand. It's not always the same molecule which will work, so we can keep changing the molecules to understand the response to the disease. So this was the response to ranibizumab when I was using ranibizumab in the same case. So this was the response, and this was the response with AFLIBERCEPT. In case 2, this is a very interesting 20 young lady who was high myope and had come with a history of retinal detachment for which I had operated long back. And post SOR, following SOR, her vision dropped, which she had regained to 618. It dropped to 660, and 3 months post SOR, I could see a myopic CNVM in this case. It all vitrectomized eye. So it was very interesting for me to see what should be done. This was the picture when it presented. I used bevacizumab in this case, though it was off-label. The response started within 15 days. The membrane started melting. The anatomy of the fovea started restoring. Within a month, the membrane almost melted away. So this is something which was very promising and which we had not seen with other anti-VEGFs earlier. So there are a lot of new molecules coming up. We need to keep our hopes on it, and a lot of studies are still required to prove these drugs. The key factor here is the membranes are different from AMD. What you should understand is picking up this at early stage is very crucial. Any early sign of dysmetamorphosia or a black spot or whatever they complain, you should have a very high index of suspicion to pick these up, because they do respond very well to anti-VEGFs, unlike AMDs. Thank you.
Thank you, Sachin, for the nice overview. Sachin highlighted few key points. The one thing is the prognosis is good in most of these myopic CNVM patients. You need to treat them early. You should not let that to undergo fibrosis and atrophic stages in the end stages. And it does respond to many of the modalities of treatment. He showed various cases starting from responding to AFLIBERCEPT to bevacizumab. The only thing is you treat early so that you prevent the recurrences and the atrophic changes which occurs according to